Purendra will take his next talk. That is on lens-based refractive surgery, options, investigations, and considerations.
C-type.
After that, we'll discuss.
C-type connector. Dr. Sen has asked one question about the epithelial thickness. So nowadays what I do is, and it's part of our pre-operative examination, LASIK workup, is epithelial mapping. That we do in all cases and see what is the average thickness and maximum thickness, and that we take into consideration. 55 micron is the cutoff, and maybe 60 microns I am taking now. So that the post-operative recovery is faster and better. ASOCT, epithelial mapping is separate, that you have to add to it. Thank you, Dr. Bharti sir, for giving me this opportunity and to speak on lens-based refractive procedures and my experiences on this. I've been doing this ICL for last almost 19-20 years, and I'm having very good experience with it. And the lens-based refractive procedures include the phakic lens and the clear lens extraction. So this is something which is meant for the dropouts, which Dr. Bhupesh and Dr. Bharti sir were not, we could not do the cornea-based procedure or laser-based procedure. In those cases, we should do it. So I'm Purendra BHASIN from Gwalior. No financial interest. So lens-based procedures are the options for refractive error corrections in eyes which are unsuitable for corneal refractive surgery. They address the eye's lens system to correct the vision rather than reshaping the cornea. So we do phakic IOL, or this includes clear lens extraction. So phakic IOL is the which we all must be knowing by now. It's an insertion of a biocompatible lens between the iris and the natural crystalline lens. So the great advantage is that it is an reversible procedure, and it does not involve the removal of any corneal tissue. So any problem associated with LASIK, or the cornea, they are avoided. It's a better option for candidates unsuitable for corneal refractive surgery. Now, in comparison, clear lens extraction involves the removal of the natural lens and replacing it with an IOL, which we have been doing since ages, and to correct the patient's refractive error. It is similar to cataract surgery, but is performed primarily for the refractive purposes in patients without significant cataracts, especially beneficial for those with presbyopia or with high refractive errors that are not suitable for corneal refractive based procedures. So the advantages are that we can correct very high myopia or high hypermetropia. Clear lens extraction with multifocal or EDOF lenses is suitable for older age group patient, as it addresses presbyopia and future cataract development also. It preserves the corneal integrity. There is a reversibility and adjustability, and there is reduced risk of dry eye. So phakic IOLs, let us go one by one. So I will be now speaking on phakic IOLs. It is advisable in patient as per the company, Star Company. They say it has to be used in 21 years of age and above, up to 45 years of age. What I think over here we do, when the refraction is stable for last 1 year and there is no change in refraction in last 1 year by more than 0.5 diopters. It is suggested in patients who are LASIK rejects, like in high myopia, when the cornea is thin, less than 500 micron, or the myopia is 6 diopters and corneal thickness is 10 diopters or so, 505 diopters, then also we should avoid it. And dry eye, significant dry eye, large pupils, excessively flat or steep cornea. So, and contraindications for the phakic IOL is that there is a presence of lens opacity, pseudo exfoliation, coloboma lens, zonulopathy, pigment dispersion, or then we should avoid any previous ophthalmic surgery, uh, any other ocular pathology like glaucoma, uveitis, corneal degeneration or dystrophy, macular pathology or neovascularization. Indications for phakic IOL are that it can be used to correct myopia, hyperopia, astigmatism or stable keratoconus. And the off-label use, it can be used for post-refractive surgery patients, post-cross-linked patient, post-keratoplasty, as in piggyback for correcting the residual refractive error post-cataract surgery, post-RK surgery, etc. Pediatric anisometropia, sometimes in few number of cases I have done at 15, 16 years of age, when the child is having unilateral high refractive error of 17, 18 diopters, which cannot be corrected otherwise, and we cannot give glasses or contact lenses to these children. And presbyopia can also be corrected with the newer presbyopia correcting IOLs, but the presbyopia correcting phakic lenses, but the indications are limited. A complete preoperative assessment is done, uncorrected, best corrected visual acuity, refraction, manifest cycloplegic, slit lamp examination, mainly to assess lens, cornea and the surface. IOP, no glaucoma, angle should be open. Topography, rather better is to go for tomography, keratometry. Endothelial cell count should be more than or equal to 2000. Fundus examination, normal peripheral retina or retinal pathologies are photocoagulated and safely time is given, interval is given in between. The two important things which are specific for the phakic IOL is the measurement of the anterior chamber depth, mainly the depth which is from the internal anterior chamber depth, which is from the posterior surface of the cornea to the anterior surface of the crystalline lens. It should not be less than 2.8, that is what is indicated. And corneal horizontal white to white measurement. These are the two very important things. So coming to my first case, which is 23 years old female with optimum pachy, but the refractive error was, as you can see, 8.5 diopters in right eye and 6.25 diopters in left eye. Right eye, we cannot, there is a risk of development of ectasia if we go with the normal full correction. So to obtain good vision and full correction, we suggested her to go for ICL for the safety, and the toric ICL was implanted in both the eyes, and post-operatively vision was 6.9 and 6.6 in the left eye. So this is the case and the surgery. I do not dilate now and before the surgery. I put, because these incisions sometimes can damage the natural crystalline lens. This lens comes in a BSS in a bottle. It's a front-loading system. With this soft spatula, the lens is taken out from the bottle and placed in the hub of the cartridge, and then it is pushed inside into the anterior chamber over the surface of the iris, and then with the help of lens spatula, the haptics are tucked behind the iris, and the viscoelastic is aspirated, and there is a central opening which is a centraflow of 360 micron, which equilibrates the aqueous from behind the lens, and from in front of the crystalline lens, the aqueous moves around the lens, and the nutrition of the lens is not hampered. So this is the toric lens, and we can see it is very well aligned. You can do a manual marking also. Another case, 42 years old female, near presbyopic age group. So with high myopia in both eyes. So what I did was, in this particular case, the pachy and rest of the things were normal, keratometry was normal. Patient had a myopia of 10.25 diopters nearly in both eyes. So left eye we did undercorrection by 1.25 diopters. So this monovision we create And by now we have done almost 10 cases and with fairly good results. In all these were of presbyopic age group, and up to 52 years of the age I have done, and from 40 years of the age group. So all these patients were quite happy with the monovision vision, which we have explained them beforehand. So now, in cases of keratoconus, as the cornea has been stabilized, keratoconus has been stabilized, and we should wait for 6 months after the cross-linking. I wait for more, and a clear central cornea should be there, and the cone also should be central. Contact lens intolerance should not is there. If the patient is not able to wear the contact lens, they are indicated, and patient's quality of life is being affected, then we should indicate. And this has been done since 2007, that the ICL is being implanted in keratoconus patients. This is a graph which tells us, like, for high corneal abrasions, cross-linking and trans-PRK should be done before, and we should make the topography and refraction stable. We should wait for minimum 6 months or more, and then we can think of planning ICL. And for the decentered cone with poor best-corrected visual acuity, we should plan for intacs and with or without CXL, and then we should wait for 6 months or more and then plan the ICL. So this 28 years old female with both eyes stable keratoconus post CXL, 14 months later we planned for the ICL. The refraction was 8.25 diopters myopia with 3.5 diopter cylinder, and with similar in the left eye also. This was the topography, and surgery is similar, and post-operative refractive correction is very good, and patients most of the time, in majority of these patients, are very happy in their visual outcome. Sometimes there is improvement in the vision also. So surgery is similar, and we have to mark the cornea like we do it in any toric IOL cases pre-operatively and intraoperatively. This I am doing with Varion, so this is without any marking. So high cylinder, the exact location of the ICL is very, very important. And keratoconus, there is a central anterior chamber depth. Usually we get a falsely high anterior chamber depth. So that has to be kept in mind, because because of the keratoconus, the posterior surface of the cornea is activated and anterior. So white to white measurement should be very good, otherwise there is a rotation of the lens. So post-operatively, vision has improved from 6/9 part and to 6/9 in both eyes, and we measure with the both eyes, then it should be around 6/6 part in both eyes. Another lady, 36 years old female, and post keratoconus, right eye squint surgery has been also been done, and there is amblyopia in right eye. Improvement in vision is 6/18 part in right eye with 1.5 and 5.5 cylinder, and in the left eye 2.75 with 2.25 cylinder. So this is the topography, and central cone is there, so we plan for ICL. So toric ICL. So 5 years outcome of EVO Vision implantable lens for the correction of high myopia and super high myopia says that the results are good, and there is no the predictable outcome is there, and there is no side effect or complications. And another study, refractive outcome and safety of ICL in young to low to moderate myopes up to 10 diopters, that also says that the results are good. So coming to the second part, that is the refractive lens exchange or the clear lens extraction. So this has been done since 1776, a removal of crystalline lens for the refractive procedure. Even till few years back, I was not doing this procedure, and I have not done it in the past, but for last few years I have started doing it mainly for the hyperopic cases. The refractive lens exchange is but over laser vision correction. The high myopes and hyperopes can both be corrected with refractive lens exchange, sometimes with superior outcomes. And refractive lens exchange precludes the need for cataract surgery in the perigeriatics. So in the presbyopic age group patient, it gives an added advantage that we can correct the presbyopia, and later we don't require to do the cataract surgery also. Laser vision correction can cause dry eye issue, which is not there with this, and makes future IOL power calculations more difficult. And the specific indications are for the high refractive errors, maybe 10, 12 diopters of 6 diopters, 7 diopters, or of hyperopia, or maybe very high myopia. The downside of clear lens extraction is loss of accommodations, and we need reading glasses. Maybe we can do the monovision, and placement procedure is more invasive than laser refractive surgery. It is difficult to implant as compared to phakic lens, and there is a challenge in accurate IOL power calculation. If you don't have high-end biometry instruments, it is better not advisable, because we will not be as correct, but unless the myopia or hyperopia is too high. So options are monofocal lens in both eye with monovision, or we can implant a multifocal or EDOF lenses. The complications which are there, the most important thing is the rhegmatogenous RD in all these cases. So various studies are there, which has been shown. This is the meta-analysis has been done. So mostly these were up to included the studies up to 2007. So with the newer machine, newer technology, newer biometric instruments, and better understanding, we can now do better cataract refractive surgery in a more predictable way. And the incidence was from 1.5 to 8.1% in all these studies. So the conclusion out of all these studies is on the right side. The increased risk occurs when the myopic eyes have an axial length of more than 26 millimeter, when the spherical equivalent is more than -6 diopters in myopic patients, age is less than 50 years, peripheral retinal degenerations are there, or there is a rupture of posterior capsule during the surgery, and NDR capsulotomy for PCO. To avoid RD retinal detachment, detailed fundus examination with scleral depression should be done by the retina person. There should be minimal manipulation intraoperatively. So fluctuation of the anterior chamber should also be managed, and what I do in all my cases now is I fill the chamber with viscoelastic before removing my aspiration handpiece. And prophylactic laser should be done if there are lattice or peripheral retinal degeneration. Other complications which is increased in number is CME, PCO, myopic CNVM, and the IOL related issues like glare and halos, and dislocation and decentration of IOL if the size of the lens is small or the lens bag is larger. Others are suprachoroidal hemorrhage or endophthalmitis post or surgery. So when not to perform refractive lens exchange in myopic eyes is when there are advanced peripheral lattice degeneration, when we see the lacquer cracks in the retina, and presbyopic eyes with macular degeneration beginning in the fellow eye, or patient is having diabetic retinopathy, etc., and other macular pathology, foveaceasis, etc. This is a young girl with posterior polar cataract. All of us will agree in myopic patients, we all do surgery if the even in the younger age group when they have a posterior polar or some cataract changes are there. We all must have done it. So with that, we got an incentive or an idea that why not to do a refractive lens exchange also. When we do it in safely and our results are good in even in younger age group without the cataract. So this was she was having a high myopia of more than 6 diopters with cylindrical power. So rest of the things were good. So we planned for a toric trifocal lens with the femtosecond laser. IL power was 11.5 in right eye and 13 diopters in the other eye. And post-operative day one vision was both eyes was 6/9 part, and with pinhole it was improving to 6/6 part. So this is the surgery, and with some PC posterior subcapsular cataract. And before coming also, I did on a young girl. She is working in some serials, acting in profession. It's a small PCC, and patient was not very happy, and she was not a candidate for the laser vision correction, or we will not do ICL in these cases. So minded many are doing, and this is the IOL power. In this eye, trifocal toric lens has been implanted, and the lens axis is aligned with the at the steep meridian, and this is the surgery. So in all these cases, IOL should be well centered, it should be well covered by the capsular axis. Our surgery should be immaculate. Posterior capsular polishing should be done. This is for the other eye, which we have done. I will take it further. And the lens is small, so we can do it with the irrigation aspiration and so hydroimplantation. The lens is opened up in the bag, and chamber fluctuation should be avoided, because then the traction on the periphery or the base of the retina is not there. So complications can be uveal effusion, hyperopia. We can do these cases, and I prefer doing more in cases of hyperopia. And the indications are beginning presbyopia with weak accommodation. For higher order aberration, when laser surgery is to be avoided, can be used for extremely short or nanophthalmic eyes or eyes with residual hyperopia post laser vision correction, and high hyperopia in patients with congenital systemic conditions. The complications in hyperopia are different than in myopia. You can have a uveal effusion, which is a known complication, and small eye, less than 21 millimeter, the anterior chamber shallowing is there, high predisposition to closed angle glaucoma due to pupillary block or secondary to rise in intraocular pressure. Complications like RD or cystoid macular edema are less as compared to the myopes. This 30 years old young girl came to us with a high hypermetropia, 7.5 and 9. We cannot do laser vision correction because we can correct up to 6 diopters. Because in left eye the residual refractive error would have been more, so we planned for trifocal IOL in both eyes, 33 diopters, and patient's visual outcome was 6/9 part and 6/6 part, and N6 in both eyes. She is very happy. And this last case is very, very interesting. 22 years old female, both high hypermetropia, very high hypermetropia with amblyopia. We did bioptics for her, and preoperative refractive error was plus 12 diopters and 0.5 cylinder, improving to 6/9 in both eyes. So these were the parameters. So IL power which came to us with IL Master 700 was 49 diopters in right eye, and nearly same in the other eye too. So because the lenses in hydrophobic acrylic category, I prefer doing in all my cases hydrophobic acrylic lenses only. So I don't do hydrophilic acrylic. So plus 40 diopters lenses are available from Alcon company, monofocal lenses. So that I implanted. I explained her, if she will not, she is not comfortable with the present vision post-operatively, we can correct the residual refractive error by LASIK after 3 months or 2 months or so. So post-operatively, vision was 624 in right eye and improving to 612 with the 2.5 diopters. and in left eye with 0.75 diopters or residual refractive error was there. So hyperopic PRK was done after 2 months of the IOL surgery, and patient vision in right eye is 6.9 and 6.12, what it was beforehand, before with these spectacles. So this is this surgery, this is clear lens extraction. And what other thing I did in this case was I did a primary posterior capsulotomy, because these young children, the young patients, there is a high chance of development of PCO in early age group. So this is clear lens, and this was done nearly 2 years back, and she has come from some 300 kilometers away from Gwalior, this patient. After filling the chamber, hydrophobic acrylic plus 40 diopters lens, and we have to use C cartridge because these lenses are very bulky, and our incision size should also be 2.8 millimeter. Otherwise, it is very difficult to push these lenses, and we have to push it slowly, and viscoelastic should be filled in the cartridge also, and lens is in place. Remove the viscoelastic, and with the vitreous cutter I will do make a central opening at in the posterior capsule. So this patient didn't had any PCO in the early post-operative period, and this is also very safe. So here, this is the left eye for this same girl. We took it after 15 days of the first eye, and I will fast forward it. After removing the lens meter, there is again 40 diopters in the other eye, and technique is same. PC opening is made with the vitrector after removing the viscoelastic, and central opening is created. But our surgery should be immaculate, and you should not proceed to go for these kind of surgeries unless until you have an experience and your results are good. So CLB is a clear lens extraction in presbyopic is to restore distance, intermediate and near vision, and we can implant multifocal or read-off lenses. The issues are the incidence of PCO and long-term centration of the IOL has to be taken into consideration. So our surgery should be without any complication, and our capsular exercise should also be adequate. And what IOL power selection and is no different from standard calculation when we use for the cataract surgery, and there is a loss of accommodation should be discussed with the patient when the patient is too young, or we may use EDOF lenses. Small degree of myopia may be desirable in monofocal IOL usage, and monovision is suggested. It is reported that in eyes with extreme axial length, the Barrett Universal 2 formula is the best, and I am using Barrett Universal 2 formula, and it has got the lowest predictive error rate. And these are some studies: visual outcome and patient satisfaction after bilateral refractive lens exchange with a trifocal intraocular lens patients in presbyopia, a presbyopic age group. And another study of this kind, and the literature also says that the results are good. And this is a study which tells us compares between clear lens extraction and phakic intraocular lens. They summarize that with advancing technology, with better newer IOL models, refractive lens exchange and phakic corrections are becoming available. And phakic IOLs provide better visual outcome for distance correction. And we should, last slide, going for the conclusion. Phakic IOL is the procedure of choice in all young patients and in LASIK rejects. And in elderly myopes, phakic IOL is the choice with monovision, or maybe presbyopic ICL if we can opt for. Clear lens extraction is opted with retina clearance and in the presence of PVD if it is there, or with early cataract. That is what my take-home message is. In hyperopes, LASIK and phakic IOL rejects, clear lens extraction is the choice of procedure. And in high hyperope, I prefer to do clear lens extraction when we cannot do LASIK or phakic IOL. Thank you for your patient hearing. That is not available. But they are available in hydrophilic acrylic category. All these Care Group and Appasamy, they make it for us. But all these lenses are hydrophilic acrylic, not the hydrophobic acrylic.